tell me a little bit about the backstory. How did you, Randy, even become a doctor?
I mean, it was when I was born, the pediatrician smacked my tushy, and my mother said, "My son, the doctor." And that was
Is this a true story?
that's what she said for all these years. I'm my
Mhm.
my grandfather, my father's side, was actually owned a grocery store and had worked as in sales and produce and that kind of thing.
Mhm.
And they had three sons, and all three became doctors. My uncle Seymour,
Mhm.
and my father was a dentist, and my younger uncle was an internist. So everybody was sort of involved with that. On my mother's side, my mother's father was a jeweler, and they had four daughters, and three out of the four daughters married doctors. So it was sort of like the process of like being involved in the family business. That was our family business. And I have lots of cousins who are first cousins, so it was sort of the second, third generation folks who came into this country and saw the land of opportunity, escaping pogroms and other things, and being able to find a way to have the American dream.
Which part of Eastern Europe did your family escape, essentially?
So it was somewhere between Poland and Russia. Russia and Poland kind of shared
Moving around.
borders at that time. So it was in that area. Then my mother's father was from Austria-Hungary.
Okay.
And so that was sort of that area. My grandmother from my mother's side was from Russia. So it was
Okay.
like Russia, Poland,
Mhm.
and Austria-Hungary, sort of my background from the family.
And you're, well, I guess, second generation from that? Is that
Well, so third generation. So
third
my dad
generation?
was born in America, in the United States. My mother was born in the United States.
Mhm.
They both were from Passaic, New Jersey, and that's they met after my father was in the war and came back. And my grandfather on my great grandfather on my mother's side actually stole the picture of my father from because he knew my grandfather and stole the picture and said, "This is the guy you're going to marry." So he said, and they actually went on a blind date and they got married very soon afterwards. And they were married for 62 years. So they had a really loving relationship and sort of, bringing that around. My mom was a Spanish teacher by training, but she became a mother, sort of, and had done worked as a dental assistant initially. And then she was a stay at home mom initially. And then, in this interesting perspective, and I think feeling very being involved long enough, to tell the whole story. I mean, she and all of her sisters had problems with weight as it was, and one of my uncles, started giving amphetamines to the all of the all the sisters and to lose weight.
Mhm.
Obviously, my mom developed a psychotic break from that,
Oh, wow.
and she ended up being admitted to Gracie Square Hospital and had ECT back in the early
Mhm.
1960s. And she left. That's really the backstory of how like I ended up getting into medicine and psychiatry. And so she went back 2.5 3 weeks. I don't have any recollection of that time, coming, but she came out and she was doing so much better. And she had this really great psychiatrist who was working with her. And so great psychiatrist was working with her, Noel Galen. And so Noel Galen, and worked with her, says, you're really smart. You should do something about, getting a career. And so she went back to school and became, went to graduate school, and she went to Yeshiva University and got her master's and postdoc and became a psychologist.
Wow.
And she was very a kind of disciple of Albert Ellis at that
Hmm.
time,
Yeah.
and the professors that she was involved with were involved, and she wanted to make sure that we all didn't kind of follow in the family neurosis. So we all were in therapy at very young ages, and she took me to. I remember very clearly going to the brownstone of Albert Ellis and walking
And
with a guy in New
for
York
the
City.
audience,
Yeah, for
Albert
the
Ellis
audience.
was, who was Albert Ellis?
So Albert Ellis was a really fascinating man. He did this whole thing of rational emotive therapy. It was sort of a cognitive behavioral therapy at the time, but he would hold these Friday evening soirees. And these wonderful soirees where people would all come and they would all be sharing information and research and commentary and back and forth. And you would be, with all the like intelligentsia of the psychological world, we're all together on that Friday evening. So
Today
I
we'd
remember
call it a live events motion.
It was like a live events motion there. So he would have it every Friday, and it was really well known that this was the place to be if you were in the psychology intelligentsia of New York City. So my mom would go, and I remember one day she brought me to meet him. And at his brownstone, he
It-
comes down with this big shock of white hair, and he comes down and introduces himself to me. So it was very, very nice. So she ended up going back to school, and I kind of got really interested in what she was doing, and got very involved in psychology, and naturally, I was the sort of kid that my friends used to always talk about, and because I've been in therapy, and so I could talk to him about things. I went, when I finished, high school, I went to Horace Mann in the city.
Horace Mann is a well thought of high school.
Yeah, it's a well thought private high school in New York City, and my first doubles tennis partner was Elliot Spitzer, who was the former governor of the state. So it's a really very smart people went there, and it was a very challenging academic environment, but it's great. I did well there, and ended up going to University of Pennsylvania.
That one.
Yeah, and at Penn, I was really interested in biology and psychology, and I was really enthralled with one of my sophomore psychology courses, and it was held by Martin Seligman. And Marty was a really brilliant guy who had a model for depression, learned helplessness. He put dogs in cages and would shock them uncontrollably. He wouldn't get out of the cages. And it was like learned helplessness was his model for depression. And eventually he evolved to become the happiness guru. And positive psychology and learned optimism was sort of the next rendition. But he was a wonderful lecturer and speaker. And I really got involved in the world. I became his research
Oh,
assistant when I was down there. And they just started at Penn a biological basic behavior major. It was actually biopsych major, which had biology and psychology and sociology, anthropology all together. At Penn, they really like to have this interdisciplinary kind of interaction. So I was like the first class of BBB majors, and really enjoyed it. And then I also was, part of the Pre-Med Honor Society, and was president of the Pre-Med Honor Society, and had all sorts of, interesting interactions. I graduated and went to NYU, New York University. I was in medical school there, and I remember when I was in third and fourth years of medical school, I did really well in medical school, and all my internist professors said, "What are you doing wanting to go into psychiatry? You're too bright for psychiatry." And I said, "No, I love this stuff." So I ended up graduating, and I went with a Columbia affiliated program at St. Roosevelt, and I was there and had some really great training experience. And I was a research associate for Alexander Glassman. Sandy Glassman was the guy who did the antidepressant blood levels and that kind of thing. And I was thinking about doing psychopharm research, but then he got real depressed when he couldn't get a grant and had to fire people. And I said, I don't like this publishing parish. I'm a clinician at heart. And so one of my colleagues came up to the Hudson Valley, New York, and was a couple of years ahead of me in residency. He said it's a great place to raise a family. And my wife at the time, Jamie, and I moved up to Poughkeepsie, New York, and started working. But it was, I think all of it, medicine was part in my blood, psychology was in my blood, and I had fascination about how the brain and the body all interacted together, and became the psychiatrist.
that story would make a lot less sense if you ended up, and that's why I'm a vascular surgeon.
My first day of psychiatric residency, Alex Kammerer, who's the head of the outpatient clinic, says, "Hey, I want to take you to the faculty dining room." He takes me to the faculty dining room. He says, "So, tell me about yourself." And I said, "Well, my dad's a dentist. My mom's a psychologist. I grew up in New Jersey." And he says, "Really? Your dad's a dentist?" And he says, "That proves my theory." I said, "What's your theory?" He said, "Well, your dad's a dentist and my dad was a surgeon. You're becoming a psychiatrist and I became a psychiatrist. Well, surgeons, they're sadists. They inflict pain on their patients. But we as psychiatrists are masochists. Our patients inflict pain on us." And he says, "It's a great dyad back and forth." So I said, "That was very funny, Alex." But, truthfully, I really appreciated the interaction. It's an honor to work with our patients, to be able to enter into their lives in a very meaningful and human way. I always appreciated that and respected that. I never, felt like I'm any better than anyone else. And I may have some wisdom that I want to impart to you, but you're an expert in your own symptoms. and together we have to collaborate to make the best treatment plan. So that's how I've operated, over the time. And for the first 25 years, I really delved into the world of psychopharm, and was a quote thought leader for those
How
years.
and how were you? I don't want to be pejorative here, but how did they seduce you?
So back in 1987, December of 1987, Prozac came out. And I was chief resident at that time in St. Luke's, and I was sort of like running the inpatient unit, whatever. We put our first patient on Prozac. And now we were the poor cousins of the rich internists, the rich cardiac surgeons. No representative ever wanted to see us at that time because all they had was, generic antidepressants and some Ativan. But then all of a sudden there was an explosion in the 90s. All the SSRIs came out, the SNRIs came out, the atypical antipsychotics came out. And I wanted to learn about it at that part. And I think I was a little bit naive, about it. And I said, well, yeah, I'll go. So they would take us away to these training programs where you would learn everything about the latest research and what got the FDA registration trials for the medications. And then I would go out and talk about it. And I would really learn, I would really go into the PI and I would go to all the different aspects. And I really understood all the, different medicines. So I would go out there and I was a talking head. And that really happened until I had another seminal experience that I taught a class, one class every year for science and technology at Vassar College. And it was on the influence of the pharmaceutical industry on psychiatry. And I read Marshall Engel's book and some of the other books that were coming on. And I recognized that, when you're a talking head, you're somebody else's person. You're not your own person. And I didn't want to be involved on a boundary that wasn't effective because, the doctors doesn't have a skin in the game when they're working for the pharmaceutical industry. And it's really the patient who's paying the prescription and the insurance company. I didn't want to be anybody's like talking head. And I also recognized that we had terrible problems like misrepresenting. Oh, olanzapine doesn't cause weight gain. And those kind of misrepresentations that got Lilly in trouble and other people in trouble. And there was major lawsuits that happened. And I kind of, fell off of doing that.
The audience, when you're doing one of those talks, do they let you make your own slides?
No, you have to use the slides that is approved by the company and the FDA.
So
And
in theory, that's to keep it compliant with the law. And that's a good thing, right? We have
you
regulations
would
on
think
marketing.
it is a good thing because there's a whole bunch of things that have changed over the course of the past 10 or 15 years. One is making it very compliant. So all side effects have to be talked about. All the registration you have to talk on label, which means you can't overpromise that these can this medicine can do other things other than what is on the FDA label. Mm-hmm. And that was kind of restricting in some way because you want to talk about your personal experience. Now, if somebody brought up a question, you could answer that question. You have to tell them it's off label. You can tell them what your experience has been, but you have to then get back to the information. So that's how they taught you along the ways. Mm-hmm. So yes, you can't use your own slides.
How much did that pay? Like, in the dollars of the day?
It could be $750 to $1,500, I think, in the day.
And compared to like how much you'd make seeing patients,
you have to take a look at the process of you're leaving your office.
Yeah.
You're going out to traveling 2 or 3 hours and doing that. It was probably a wash on some level, but
this is kind of my point. It wasn't a big money gig.
It was not a big money gig, but on the other side, there are people who did a lot of them and put them and they set their time aside. So there are people that make $100,000, $200,000 a year with talking. Even in general practice, you get bigger bucks if you're doing that from an academic institution.
And so some people made a significant amount of money, but aripiprazole, Abilify, was $6.9 billion in sales annually at its peak, something like that.
No, it wouldn't be more than I do making a day job. Now, there is obviously some aspects of it, Owen, that you're out there in the community, you become a leader, it establishes your reputation. It's kind of like doing some marketing for yourself.
Hmm.
out there. So I kind of like that. I got to meet people. I got to interact with people, which I think helped my practice and my reputation. So that was also part of that.
So it's nice to feel like an expert.
Yes, it's very flattering, and I think that that's what ends up happening now that I'm so pulled away. The representatives who come into your offices, oh, you're a thought leader. Do you want to talk for us and that kind of thing? And I, right now I'm deferring. Obviously, I'm not doing that. I'm not doing this at this stage of my career, but it's something that is very flattering for a lot of doctors. And I really think that it does a disservice overall to just have the same people doing the same things over and over again, talking about the same things. And so, how many lectures do you need about a particular medicine like Abilify or Vraylar? It's a little bit much. And I think what the marketing folks have definitely said from the big pharma, is if I see a doctor, that doctor's or nurse practitioner is more likely to prescribe that medicine. Now, the other side of it, and this is something I think is important, sometimes a new medicine comes out and we don't know about it. I don't mind speaking to a representative about something new that's come out, that and give me all of the literature and let me look at the PI, let me understand it. And so I will, talk to a representative if there's a new medicine out, just to get a sense of what's going on in the community.
And at a certain point that broke for you. And was there a moment where you thought, well, this doesn't make sense?
I mean, so when I was giving this lecture at Vassar College, and I did it like 4 out of 5 years, and you had some tough customers there. You know,
They're actually college students asking
they're
real
college
questions.
students, and like I had to justify. It's like, well, why you're taking money, for this, and I kind of understood that. For my own integrity, for my own ethics, Marsha Engel's book was really a good one, which sort of says, well, a lot of the money that is happened is being made by big pharma, but it's academic institutions doing the original research, and then the big pharma buys the original research from the academic institutions, and then they margin it up. And it just didn't make me feel good to be sort of the thought leader for that group.
Mhm.
And also the other thing I will tell you, Owen, I found TMS.
Oh.
So it was back in 2006, and one of the things that I had, one of my patients back in this area, and I give him a shout out because he's a great guy. One of my patients was high up in IBM, and I was working with him for about 10 years. And he says, I can't stand the medicines. I can't stand them anymore. Can't you do anything? I said, well, there is ECT. So I don't want the memory loss associated with ECT. I said, well, I've heard about a new treatment called TMS, and that at Columbia, where I trained, they're doing the clinical trials.
Hmm.
So I just called and I said, can I get the brain stimulation program? And who picked up was Holly Listenby. And so Holly was in charge of the brain stimulation, and she spent about 25 minutes with me talking about the research, talking about the promise and what you look forward to. I said, that's really interesting. So then in October of 2008, the FDA granted the approval for the NeuroStar TMS therapy system. And so my patient was right on it. He says, so when are you getting your system? I said, yeah. When are you getting your system? So I contacted Neuronetics at that point, and Joy Patermo came up and spoke with me, and we spent about 4 or 5 hours talking about TMS. And I then went down to Philadelphia, and Mark George was giving the first talk. The first 75 people in all the United States were there who had TMS systems. And so Mark gave the plenary talk, and I said, I got to be in this. And so we bought our first system at that point, and we started the fall of 2009. We started treating
Hmm. So you were
patients.
in essentially cohort one.
It was cohort one, the first 100, clinics in the country that were doing it. So
And what was different about the sales pitch, as it were, of early TMS compared to what you'd heard from Pharma
I think,
One?
yeah, well, there's a real big difference in the fact that you don't have an insurance company at that time paying for it. So it was not reimbursed, even though it was FDA cleared. All the insurance companies called it that it was experimental at that time. So we went through a big push about fighting the insurance companies and doing appeals to the state. And it was over and over and over and over again. And the numbers of patients, especially in my community, I'm not in the big city. I'm up in Hudson Valley, where people didn't have lots of wealth. associated with it. So people were, taking some of their savings, and they were borrowing money, and we were fighting with them to try to get the reimbursement. Finally, in 2013, Medicare gave an approval for TMS, and then all the other insurances came around. So that made a big difference in the
Hmm.
process of getting approvals. And now we see that there's over probably 320 million people in the United States that have an insurance policy that covers TMS.
And your family have been instrumental in some of that, if I remember correctly.
Yeah, I mean, I think I had one site here in Poughkeepsie that I was running as a group practice, and then COVID hit. And then when COVID hit, about a third of TMS practices in the United States paused, and we were one of the third. And New York City was an epicenter for COVID at that point, and we didn't know how it was being transmitted. So we quickly went to telehealth, and we held TMS. And I said, I've been cutting and pasting Zoom links. It takes me an hour every day to do this, and could you help me out? And he said, "Sure, Dad, I'll come and help you." In an hour, he fixed it, so I didn't have to cut and paste Zoom links. And then I said, I'm not. I was just elected president elect of the Clinical TMS Society, and I'm not treating any TMS patients. And he says, "I'll do it under a couple of conditions. I have to see if the business makes sense. But second, I want my son, my brother Logan, to be involved." And Logan is a lawyer, and he does employment law. So they both came in and started working with me. And we started back after a couple of months, treating patients, and started growing. And so now we're going to be opening up our 10th site in Syracuse. So we now have 10 sites, and Logan and Connor are Connor came full time in October 2023, and Logan's working, and we really are building out both general psychiatry, TMS, and Spravato sites throughout New York State.
And
And so, as far as the insurance, we actually wrote lots of letters to Letitia James, because Letitia is the Attorney General for the state of New York, and it was very important for her to have good mental health care in the state of New York. And we worked with the insurance committee of the Clinical TMS Society to write letters of support to develop a Medicaid policy for TMS. And as of October of last year, there's a policy in New York State for TMS for Medicaid. And so we're really excited. And now what we really want to do, and this is sort of our vision, is in New York State, we really want to provide accessible care that's affordable for patients in New York State. So we take Medicaid for TMS, we take Medicare for TMS, we take managed Medicare, managed Medicaid. We really try to be an open door for patients who are struggling with treatment-resistant conditions,
can
psychiatric
can
conditions.
can you explain a little bit more about what TMS is and why what it is important for patients who may be Medicaid beneficiaries?
So a couple of things. First, I, to for full disclosure, I'm also the president of the Foundation to Advance Clinical TMS, called FACT TMS. And so while I was president of the Clinical TMS Society, the board of directors of the Clinical TMS Society supported the formation of a foundation. It's a 501c3 charitable organization to increase access and awareness of TMS therapy around the world. So it's very important to me personally, as well as to my board of the foundation, as well as to my practice, to provide affordable care for
Mhm.
TMS.
Which for the audience also includes my wife on that board.
Yes, and Carlene McMillan's on the board, and what a wonderful addition to our board as well. So transcranial magnetic stimulation uses an MRI strength magnet, and we stimulate the areas of the brain that are either underperforming or underfunctioning, or overperforming or overfunctioning, and we really help balance the brain's activity. Um, and I really do appreciate. I was watching your podcast, Owen. I love the idea of fine tuning the piano, like getting the piano tuner. We're tuning the piano so you can make good music. Or I often use the metaphor that with the brain is an electrochemical organ, and you can affect the electrochemical accuracy of the brain through TMS. And it's kind of like getting your brain tuned, like you're getting a tune-up for your brain. And when your brain's tuned, it works really well. And so it's been FDA cleared since October of 2008 for treatment-resistant depression. It's approved for augmentation for obsessive compulsive disorder. It's approved for adolescents age 15 and up as an augmentation strategy. It's approved for smoking cessation. It's approved also for migraine headaches. as well as there's accelerated programs, protocols such as the Saint and the Brainsway Swift that's approved as well. So there's a lot of movement and a lot of excitement in the field of transcranial magnetic stimulation. And so as far as for the Medicaid population, we know that the severely and persistently mentally ill struggle with being able to work, struggle with being able to have consistent employment over the course of their lives. And a lot of times they end up needing social services and Medicaid and Medicare.
And
And
just to zoom in on that, so Medicaid is insurance for people who are not well to do, right? Medicare is for older people mostly. Sometimes it's also fully disabled people. But Medicaid is insurance created at the same time as Medicare in the 1960s that takes care of people who don't have any money.
correct.
And one of the things you're highlighting is that one of the reasons people might not have any money is because they are crippled. They can't
And
work.
they can't work because of their mental health condition. And one of the things that I've just been so amazed about is I would probably say somewhere between probably a third of our patients are on some form of public assistance that we treat.
Mhm.
And I really find it such an important value for me to be able to help those patients. A lot of times people think, oh, TMS is only for the wealthy. No, 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 no. TMS is for patients who are really struggling. And we know that depression and OCD go through socioeconomic strata. Doesn't matter if you're poor, if you're rich, it can go through all data. But the extra burden of having a mental illness and struggling financially is onerous. And that's why we feel so good about being able to support those patients. And we also get, interestingly, mass transport, Medicaid transport. So, a lot of times, with the non-accelerated protocols, you have to come in daily
Mhm.
for a period of 6 weeks, and we support our patients in getting into the treatment effectively.
And so if you have Medicaid, and many people who have Medicaid are disabled in some meaningful way, but you also can qualify for a service like medical cap.
Right.
And
Medical
so
transport.
and so you work with medical transport to help get patients who might otherwise be housebound to the clinic to be able to get this treatment. What is the change like for someone, who comes in on the bottom rung of the ladder economically, but also emotionally? I mean, they're definitionally depressed if they're getting, TMS, or maybe they have OCD or other, related conditions, but that's what insurance usually covers. They come in and tell me kind of the walk me through the patient walking in the door on day one and what they look like when they walk out at the end of the treatment.
I mean, so I'm going to say that the vast majority of our patients have a positive response to TMS. And what does that mean? There's functional improvements. They're able to have better mental energy, better physical energy. They're able to do housework when they weren't able to do housework. They have better concentration, better motivation, better interest that they didn't have before. Um, I don't know how many times, and I know, Owen, you've seen that too, where it saved my life. It saved my life. And occasionally you see that in the world of pharma, where we give a medication, oh, that really made such a huge difference. But this
Mhm.
is every single day when I'm going to our patients and how are things going? It's made such a difference, such a huge difference in my life. And I think, and the other thing that I often talk about, the quality of the change is different. A lot of times with medications, what we find is it takes the edge off of the negative emotions, but it doesn't enhance the positive emotions. Depression is the presence of negative emotions and the absence of positive. TMS gives you both. It gets rid of the negative emotions and enhances the positive emotions.
It's
Um,
a motivation transplant.
it's a motivation transplant. It gets that dopamine system, which is the motivational system in the brain, on back online. Again. So people can start. One of our patients said to me early, I found myself dancing again. I found myself singing again, which is something that they weren't doing before. And even some of the patients who say, well, I don't know necessarily, and this is something that I often see is, they're used to being depressed. They're not used to not being depressed, right? And so I'll see the husband. How is it? Oh, yeah, she's so much better. Well, I don't know if I'm better. Well, did you know that you actually were reading a book which you hadn't been reading before? And then sometimes eventually, yeah, patients, yeah, I did make those changes. And so sometimes the other aspect is you got to break that depressive character along with, once you get the brain back online, the depressive character also. And that's where psychotherapy comes
Hmm.
in, where you can really assist the TMS by engaging the patient in psychotherapy.
And can you tell me a little bit more about how you at Clearwave, your group, think about the role of psychotherapy? Uh, I mean, you grew up, around and about psychotherapy royalty.
Right. I
Uh,
mean, so I think that, we felt so much that our we were much more heavily, I was a medical model. At one point we just had psychiatrists or practitioners, a few therapists. We recognized that we wanted to build out our psychotherapy model. So we have currently 8 therapists that are working with us, soon to be 9, and we're growing out our therapy practice because we really do believe the combination of psychotherapy along with TMS and even therapy. Gerald Claremont back in the day said, "Oh, psychotherapy along with medication management gives you the best response to depression." So we really do see that. I think one of the areas where I see it being beneficial is if, for instance, I feel like I am better. I want to go out, but I'm frightened. I don't know what it's like to be not depressed, especially if I've been depressed for 10, 15 years. And that's where I often say some cognitive behavioral therapy might be helpful for patients. Some motivational therapy might be very helpful for patients while they are getting their TMS.
and might be very helpful. What does very helpful actually mean in their life?
I mean, I would say that so with our patients, I think that helpful means that you have a wise person who is understanding about your mental well-being, understanding about the challenges that you've been through, and is going to be a guide to assist you in having as full a life as possible. And the importance of the relationship and having a therapeutic and healing relationship is really very important. And it may not matter what the type of therapy you might be having. It's really about how a holding environment, a caring environment with a wise person who's really genuinely interested in you, then in that trusted environment, you start analyzing your perspectives. You start analyzing yourself. You start analyzing yourself in your relationships. You analyze yourself in your history and start to say, maybe I can change my internal perspective and adjust it and accept that I'm worthy and accept that I have a value in life, accept that I am worthy to not be involved in dysfunctional relationships. And I'm going to work hard on managing that and making it a difference.
Hmm.
So I see therapists as being, wonderful guides for our patients.
On the journey to worthiness.
Yeah.
Um, let's pivot here. I'm curious to hear your take on. There have been so many new innovations come out the door in the past, maybe 2 years, and more on the way. What have you seen that's the most exciting and promising to you as someone who has spent a lot of time with this one modality, TMS? But now we have all these other things. What has struck your fancy or captivated your imagination about what could be next for our patients?
I mean, so it's I do love TMS and this platform technology. How we do TMS is really exciting. And so being very close to some of the leaders in the field of TMS, um, I think that we can be giving TMS much more effectively. Now, whether that's using functional imaging and making it low cost so that it can be used more effectively, looking at that you don't just have to hit one spot in your brain, you might be able to hit more than one spot to get more efficacy for patients. So I think making TMS more effective so that instead of it being 60% effective, it's 90% effective. or even more than that. So that's one area. I do think wearables might be down the road. Um, ProLive RX, there is a trigeminal and occipital nerve stimulator. I thought that was pretty cool when I
I've
went to.
heard.
It's pretty cool. I had it on me. I don't know if you probably have. Had it on me and tried it on. So having something that's able to be at home, some app-based changes that would be very helpful as well. And
Mhm.
we are also doing Spravato therapy. So I think the psychedelics are very, very interesting about making
Mhm.
fundamental changes for patients. And so I think that that's also very exciting for our future. So I think that just the standard monoamine serotonin reuptake inhibitors, the SNRIs, that may actually be in the past. Well, how did we ever do that when we come in the next 10 or 15 years, when we're going to be doing much more transformational changes with neuromodulation and potentially some of the other psychedelic treatments that are down the line?
If you're uh, talking to someone in your life, and as happens to me all the time, I mean, I'll hear the stories from people who know me socially, um, and they hear about what you do, and suddenly they become very interested. This, at least for me, puts me in a tough spot. I'm not your doctor. I'm your friend. How have you navigated that being kind of an utmost expert in the field and then having people in your own life who are suffering? How do you help people who your friends, loved ones, with, etc., uh, navigate this crazy system when they come to you and you know all that you know, but you kind of can't be their doctor? How do you get out of that
It's,
trap?
so I will try to find trusted sources, other people in the community that I could refer patients to. I do that. I mean, one of the things that I feel really good about being in my community, I got some great doctors that work with me. So if I happen to know somebody in the community, I can say, well, I've got this, doctor here, I got this doctor there that I can refer you to that I think is really very good. It's not me working with you, but it's actually somebody that I vetted and I feel is a really good, doctor or nurse practitioner that can work with you. I think it's important to have appropriate boundaries, of being, helpful, and don't ever write a prescription for one of your friends, that kind of thing. But I usually say, look, I can't be your doctor, but let me listen. I'm a human being here who has some wisdom. Let me listen to you. Let me hear you. Let me hear what you're going through. And then, I mean, that's one of the wonderful things about being a psychiatrist and really being trained, is being able to really empathize with our patients, see the world through their eyes, and then be able to understand what to do to be able to help them. And it's usually giving them some advice. It's usually recommending appropriate resources and referrals, and even making that extra call. Say, hey, I have a friend of mine, and calling the doctor. I think is a really good patient. I think that I would really appreciate if you could take that person on
So there's a support and listen and phone a friend.
and
Those
phone a friend. Do that a little extra warm handoff.
warm handoff. Um, what's it like working with your kids?
It is one
Sounds
of the
like they're
most,
integral, but tell me.
it's one of the most wonderful things, and at times very frustrating things about. I mean, you work with your wife, you sort of understand that. The wonderful things is you never get usually to see your children work in an adult fashion, an adult way. You hear about it, right? If you're a parent, you hear about it, but you're actually seeing how your professional children are interacting in the world of a medical care business. And they surprise me in really lovely ways, about professionalism and intelligence and support and all the great ways that they do. It's very frustrating because I used to be like in charge of everything. And I used to be like, if I wanted to do things, I did it. But now it's like, no, you can't do that, Dad. You have to sort of follow. This is the line of chain of command, and you have to follow that. You have directors that handle that. No, you can't just jump in and say you can do this. So I had to kind of pull away and say, like, it's no longer just my mom and pop, shop, but it's now an organization that I have to respect its boundaries. And
Pardell and
so
Sons.
What was that?
Pardell and Sons.
And Sons, and it's like, yeah, well, yeah, and obviously, Connor had worked within corporate settings, and Logan is an employment lawyer. That's he has his own practice, but something beyond what he does for us. So it's like we have to be appropriate in the way that we interact with our staff, and we've really brought in some really lovely ways of providing support for our staff, encouragement for our staff, benefits for our staff, so that they feel that they're well taken care of.
Um, what do you think your sons would say about working for you?
Um, I think they really like it. I think they are proud of what we're building together. Um, I often say we have our own lanes, right? And I have the clinical lane, and I'm really passionate. I mean, I'm just really passionate. I mean, I don't feel like I'm slowing down. I'm like revving up right now, Owen. I'm really enjoying the work that we're doing. And they have their lanes in the legal aspect, in the health and human resource aspect, and in the aspect of being the CEO. That's Connor's our CEO, and Logan's our corporation counsel, head of human resources. So everybody's in their lane, and I respect their lanes. They respect my lanes, and as we do this, we can be most effective.
But you report to your son.
I report in the organizational hierarchy. If you follow the organizational hierarchy, yep, I report to my son. I mean, we all are co-owners of that, but I
Mhm.
report
I
to
mean,
my son.
my dream and Carlene's dream is to report to our children as well.
Well,
We
you can. I'll give you some tips along the way, but it's really very lovely to see that they really appreciated that or actually chose to come to work with me. Actually chose to come to work with me, which meant like I did okay. And my wife and I did okay in raising our kids, that they actually feel comfortable that they want to, spend the time that they do to help build something that we're doing together.
Many kids want to get the heck out of the house, and they
Right.
are not necessarily coming back into the office.
But
Uh,
it's great. We have both of my sons have great wives, and I just welcomed a granddaughter, Sloan, 3 months ago. So I'm excited about being a grandparent, and so that's all the rewarding aspects, as well as very rewarding in helping so many of our patients. That really gets me. Just I'm sure you feel that way. It's like, yeah, let me go in there. Let me help them. Let's keep on helping our patients.
So the story you heard on that day one in the faculty dining room was off by a little bit. Surgeons inflict, pain as it were on their patients to heal them, and maybe sadistic in that, joking way. And
Right.
psychiatrists, it's not the patients inflicting pain on us at all if we're doing it right. And at Clearwave,
Right.
um,
They give us a lot of rewarding experience. Um,
but we are a little bit masochist because we have to go out and figure out how to get the insurance companies to
that's where
actually.
the masochism comes. That's the one that hits over the head.
And I'm curious, you have to be careful with what you say. You run a not-for-profit organization. Do you have sincere advice for our colleagues who are working at payers for how they could think a little bit differently about TMS to help them catch up with this? I mean, what you've described as a tidal wave of change over many years, but all in the direction of more TMS, not less.
Right.
Every time TMS has been evaluated, eventually it's determined that, yeah, this is a great option and more people should have access to it. So what advice would you have for our colleagues who are working at payers when they're reevaluating TMS or any new technology for how they can get the show on the road?
So it's really interesting. Just to let you know, we're going to be having the foundation has a free webinar that's going to be coming out in next month. Yeah, it's going to be on September 29th. Factms.org is the our website. And Sam Huber, who is a medical director of MVP Mohawk Valley Plan, is a medical director of the neuromodulation program at this insurer. And he's going to be one of the guests, and I'm going to be one of the guests, and Ian Cook is going to be the moderator on that. And so we're going to talk about that. I would love TMS to have the openness that, say, another neuromodulation treatment, ECT, has. That you can do maintenance treatment. You can use it for bipolar depression. You can use it for patients who may have, I would love it when, if there's enough data that eventually comes, who have auditory hallucinations, visual hallucinations, be able to appropriately treat those severe illnesses with this wonderful technology. Um, so usually what you see in the process is two different directions. One is direction, what's the evidence basis, right? That these conditions are work. So we need the double-blind randomized controlled trials, and that's why, in my heart of hearts, I would love that the Foundation for the Advancement of Clinical TMS is able to get enough money to be able to support double-blind randomized trials. That would be great for other conditions like bipolar depression, like it could be schizophrenia and other illnesses. And so then we could say to the insurance company, evidence-based. And then the other is a value option. That if somebody is not doing well, right, and they have more hospitalizations and more medicines and more debilitations, it's going to cost the insurance companies more to care for patients who are undertreated. And so if one of the things is we are an observable treatment, TMS is an observable. You make sure that the patient actually gets the treatment. And so, especially if we can get some accelerated protocols that go very quickly, so it can be done within 1 day, 5 days period of time, you can definitely make sure that the patient's getting the treatment. Then you could say, hey, it's effective, patients are getting it, it is cost benefit is there, and it's effective. And if you provide that to our insurer colleagues, that they can be convinced, then you're going to start to see more and more conditions approved by insurance companies.
So you really think that it's going to take yet more evidence?
The two different ways I see it is yet more evidence, or you have registries, large registries, where
Mm-hmm.
you see patients who have, like the Neurostar registry, where you see patients who have significant benefits.
Mm-hmm.
Uh, it's done in a naturalistic way, and the FDA is convinced that this just what happened with adolescent depression.
Mm-hmm.
The FDA was convinced that the majority of patients who were adolescents age 15 and up, um, who were on antidepressant medications and got TMS, did well, did very well.
Mm-hmm.
And so they gave the approval for 15 and up. And then all the insurance companies came along, or most of them did come along.
Mm-hmm.
So that we could also, that's the other avenue to really help with registries. And that's something that I would like the Foundation for the Advancement of Clinical TMS to also
Mm-hmm.
support.
And um, I mean, you both succeeded and failed as a parent. Neither of your children are doctors. Are there more than the two that I
Just
know?
the two boys.
Just the two. They didn't end up as doctors. They did end up in healthcare anyway.
They did, and they probably. I mean, I love being a doctor. I really love. I feel like how cool is it using science to help heal people?
And and bring
It's
motivation and joy as you
and motivation and joy. It's just it's wonderful. Now everybody's got their own drummer. I'm thrilled that my kids are involved in the business aspect of healthcare, and they could say, hey, buy this, and this is where I kind of like the chief medical. You're a chief medical officer. I'm a chief medical officer. That you can have an effect on a lot of people. Through your operating procedures, your policies, your training, that you can actually benefit so many people, thousands of people.
and if you're giving advice to our readers and listeners about whether they're going to be a doctor or not, would you still say they should be a doctor?
Uh, Everybody's going to ask the situation of, what's in it for me. If you enjoy having the ability to have a personal relationship with somebody and using your skills to heal people, there's nothing better than being a doctor to do that. It's expensive being a doctor. If you have to get 4 years of college and 4 years of medical school, and you have a lot of loans, that come out for a lot of our physician colleagues, and that can restrict some of your options if you have a lot of loans. There are some lovely, my alma mater, NYU, gives free tuition. So if there's wonderful institutions where you can get free tuition, so it's not so onerous, that's great. They're starting to see some of medical schools getting endowments for that. If you have that, that's great. Become a doctor. I think it's wonderful. But I think every person has to, answer that question for
Mhm.
themselves. There is calling, there's profession, and then there's job. Um, and a job is a job, 9 to 5. You do it so that you make money, so you can support your family and have some life afterwards. A profession, you do the extra study, right, to get some extra skills so that you can make more money. Um, but a calling is, this is what you do through your whole life. It's calling you to do that. I know you have that calling, Owen. Is like, what are you doing on the weekend? Well, I'm reading. I'm learning about my field. I want to know what's going on, and I want to come back. I want to, teach this. I want to help my patients here. And when you have that calling, and you definitely see that in medicine, there's a lot of people who feel like medicine's a calling.
And so for many of us, it's not like the advice about whether to be a doctor or not doesn't matter because for people who are going to do it, they kind of had to do it. It was a calling. They weren't
It
going
was a
to not.
calling. And it's just so expanding. The science is expanding, the learning is expanding, and I mean, with AI, you can be so much better doctor. I mean, I remember used to carry my Washington manual in my lab coat, like kind of getting through it, and now you have your little phone, and you can ask the questions and get the answer. So you can so much more be an effective doctor, and and really be a good agent for the benefit of your patients.
And now a completely self-serving question. What's your favorite Some Frontier Psychiatrist article? What's the one maybe
I mean,
you made note for?
I really enjoyed the interview that you had with Mark Horowitz. I mean, it's I keep this right by my bedside. And it was so nice, and I think refreshing how open he was, and open you both are, about the struggles and importance of recognizing we're human beings too, and that we should be very closely aligned to our patients. Understand that we're giving them a pill. What is that pill causing? What kind of benefits? What kind of side effects? Be very aware that that some patients are going to have a real hard time getting off their medicine, and that we have to be very sensitive to them.
Mhm.
So I really appreciated that part of the podcast. It was really wonderful.
It was Mark is a fascinating character because he had the humility as a scientist to go and like look past the answers that were in the literature, which he just had a hunch were all wrong from his personal experience and ran at it like I every once in a while I'll see a thing that he'll say on Twitter, for example, because he's a personality there, and I kind of wince like that seems a bit much, but he's an evangelical. He cares that people suffer less, and he
Mm-hmm.
can't not care. It's a calling for him that he came by so honestly. In full disclosure, I'm actually an advisor to his company, Outro Health, and good friends with his co-founder Brandon as well. And we're just on the phone yesterday talking about how qua your point that we'll be questioning why we ever did this with SSRIs. We have we studied them for 6 weeks and then prescribed them for 20 years.
Yeah.
And there's not a lot of evidence guiding that practice. And it also raises questions about, well, when you think as kind of a closing thought about how TMS is different, you said it added something, it didn't just take away negative feelings, it adds positive feelings for some people. Is there anything else that's meaningfully different that you'd want to kind of like notify people about when you
I
think
mean,
about?
it's the absence of side effects, and there's no withdrawal effects. Patients can finish up their TMS. They don't feel like, oh, I go through withdrawal from TMS. The side effects are mild local site sensitivity and headache. There's a loud click, so you have to wear hearing protection. Rare risk of seizure. We've done probably 121,000 treatments, and the one person had a seizure. It wasn't due to TMS. They had stopped their Xanax. So it's something that, now that we know the safety guidelines, very unlikely to happen. So universally, patients tolerate the procedure very well, TMS very, very well, In fact, people often say, no, we do more of the standard, not the accelerated, more of the standard 1 day treatment. How do you do that? How can you get people to come for 5 or 6 weeks? They like to come. They love our texts. It feels like my spa day. It's my time away. And actually, I call it like a mini day program, for patients that they feel supported and care about. A lot of our teachers are great. They're all great, but they're like a lot of pre-PA, pre-med,
Mhm.
pre-nursing. So they get their time in with the patients. They really care. They're very passionate about helping our patients. So
Okay.
in all, it's a win-win.
Okay. How do the readers find your group?
It's clearwavementalhealth.com. You can find us on the web, and facttms.org. If you want to donate to the Foundation for the Advancement of Clinical TMS, we provide patient assistance. So if somebody can't afford to come, we will provide patient assistance. We also provide grants, both in psychiatry and neurology, to support original research in psychiatry and neurology as well. And so we're really looking at also increasing awareness, and we're going to be redoing our website, and we're going to be having podcasts, we're going to be having social events. We're really going to try to start having our free webinars. So we're really trying to have a place, and I often say the difference between the Foundation for the Advancement of Clinical TMS and the Clinical TMS Society. The foundation is the heart, the Clinical TMS Society is the brain, and our heart is really want to focus on the patient and helping patients both access TMS, become aware about TMS, helping families as well, and supporting groundbreaking research.
So it's
To
a pretty simple call to action. If you've heard Randy talk and you want more people to be able to get access to this, a donation to the Foundation for the Advancement of Clinical TMS means more people get access to TMS treatment at a lower cost to them, and there'll be more research supporting the next person who needs it so that their doctor can answer the question of, is this right for them? That's what I'm hearing.
absolutely, well said. Thank
Okay.
you.
Duck the landing.
All right. Take care now. Thank you so much, Owen. And now that you can sort of say at the end of this, we don't have to talk about what we're going to say. We just
It turns out it was just fine.
all right. Take care now.
Good structure. We'll get it right next time.
All righty. Take care now.
Thank you.
Bye bye.